Without objection.
When this committee was debating the Affordable Health Care Act, I was concerned about several provisions I believe that would decrease individual choice, open the door to government rationing. There are 4 rationing, I'm not sure what to call them, or groups, and you are one of them. CIMI was one of these creations of this proposal, and we have before us a proposed demonstration project or test, as the agency's press release called it, that could disrupt care from some of Medicare's most vulnerable patients. By the way, Dr. Conway, thank you for being here today. I wanted to first share with you some comments and questions from a couple of constituents in Kansas. Eileen of Overland Park suffers from hypogammaglobulinemia and lupus. She wrote to me asking, is anyone at CMS looking at the possible effect of such a demonstration on the people it will impact? Do any of them care that good, honest Americans will die without access to these treatments, or are they merely trying to save money by cutting costs? Their proposed actions will at least cause a degraded overall health outlook for many rheumatology, arthritis, and other patients, and will certainly sign the death warrant for many patients like me. Another constituent, Bradley from Wichita, wrote the CMS experiment excuse me, is an intrusion on the close relationship our doctors have with patients and their clinical decision-making. This experiment will backfire, costing patients and taxpayers even more for cancer care. Now, according to the statute, CIMI is to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care. That's where I think we're running smack into trouble. How are you going to ensure the beneficiaries don't have trouble accessing appropriate, timely treatments in the setting they prefer? I give the example of a patient going to a rural oncology doctor in a rural area sent to a hospital about 100 miles away. Is there any data indicating these proposed payment changes will improve quality of care or patient outcomes?
Yes, so first, the goal of the Innovation Center is to improve quality, as you said, or maintain quality. And I will say and this is what I've been doing for 20+ years, both in the public and private sector, the paramount importance is improving quality and better patient outcomes. It also, as you said, is to maintain or reduce expenditures. In this specific proposal, we are proposing a value-based framework in Phase 2, which from the private sector, from private payers, from pharmacy benefit managers, from providers, has been demonstrated to focus on paying for value in medications. We're proposing to test that in Medicare Part B, and we do believe it can maintain or improve quality, and that is our primary focus, is on the quality side of the equation.
Well, on that issue, and pardon me for interrupting, but I have very limited time, under the ACA, the Secretary is prohibited from using comparative effectiveness research findings in determining Medicare coverage. However, in Phase 2, CMS plans to test paying for drugs based on how effectively it treats different conditions. Does CIMI believe it has the authority to waive this prohibition? Are you doing what you shouldn't be doing?
So in terms of the CMMI or the Innovation Center, we're proposing to pay for value, which can be things like risk-based sharing arrangements based on outcomes. It is consistent with the statutory authority to test new payment and service delivery models. I would highlight on CMMI broadly, we've got thousands of providers in every state in the nation engaged in delivery system reform. We've got millions of patients that have received, in many instances, demonstrated by independent evaluation reports, improved outcomes, improved care experience, and we can certainly talk about that more. I know we're tight on time.
Thank you, Doctor. I appreciate that. Let me just say that you have said the public comment period for the proposed rule concluded on May 9. CMS is carefully considering all the public comments on this proposal that received by the comment period. We value public input. We look forward to continuing work with stakeholders to maximize the value and learning from this model. I think that was mainly about Medicare pricing facts, and that is in direct conflict with the letter that we have here from 32 patient groups that say There was a lack of stakeholders' input from the beginning of this process, and many of the problems with the demonstration could have been mitigated had patient groups been involved on the front end. I think what we have here is a failure to communicate. I remain gravely concerned about how this demonstration or test, as the administration calls it, will impact patient access to care. I would like to reaffirm my request, as all of this side of the aisle has requested. I'd like to reaffirm my request that CMS simply withdraw this proposal. Thank you, Mr. Chairman.
Well, thank you. Senator Menendez is not here. Senator Thune?